Before I got sick, I had this idea, a vague idea at the time of a bucket list. What would I do? Where would I go if I found out that I was short? So I kind of imagined these things that I wanted to experience. One of them was to go to Stonehenge. I wanted to visit Stonehenge. I also wanted to visit the Max Planck Laboratory in Germany. I also wanted to see the Bosporus and the Dardanelles, the Parthenon, the pyramids, Mount Fuji. So these were some of the things on my bucket list. I didn't imagine that the end was going to come the way that it did. And so I had this journey planned, which if you've been following my content, you know that I was wanting to travel back east to reconnect and experience that joy of reconnecting with people that I haven't seen in so long, and that I had this urge, And now that I'm so sick, I can't do that anymore. For a lot of physical reasons. I'm not going to get into any gory details. But the point is that had I known 13 months ago, I was diagnosed with this vile illness in May of 2025. And now it's June of 2026. And I am basically too sick to go to anywhere except clinics and the barbershop across the street. And I rely on the kindness of our friends and neighbors who love us and we love them, or the handicapped shuttle to get around. But it seems that because that diagnosis was delivered then with an inadequate preparation for what was going to come. I knew some elements of the progression of this illness, but I did not have a comprehensive view of where I would be 13 months afterward. I believe that this diagnosis should have been delivered in a room, in collaboration with the doctor, not just the NP who did it in a text message, and that there should have been a wholesale preparation on day one for things like medical power of attorney, the POLST form, which is a POLST. It is a portable order of life-sustaining treatment that a patient can carry around with them. Anyone, not just a terminal patient, but it has boxes to check for what you might want a provider to do in the event that there was an emergency where life-sustaining treatment could be administered. And also, 13 months ago, I was a lot healthier and I was a lot richer. So a lot of these bucket list things that I possibly could have done, I'm not saying I would have. I might have been able to go to Stonehenge. Could I have made it all the way to the Dardanelles? Who knows? But we'll never know now, because that opportunity is gone. And this opportunity, and so I guess the subject of this really is anger, a lot of anger that I have internalized, and it hasn't been helpful to this. And I realized that what I need to do perhaps to move past this is to forgive them, and just to kind of hit the reset. The way we reboot our laptops or tablets or phones and such, just to clear the cache and kind of start afresh, sort of. And I don't want to sever this connection. I think that it is valuable. However, the workup for this diagnosis, perfect, I guess. Although I don't have any medical expertise to critique that one way or the other. But the timing of the diagnosis and the manner of of the delivery and the absence of clear information about the progression of this illness and how it might go. And so do it in a big room, with the patient, the spouse, or whomever is there. So let the wailing and the gnashing of teeth, get it all out of the way right there. All the questions need to be asked. The tears can be wiped away. Everybody holds hands. That's the way I would envision it. I don't think that that's the way that most providers envision it. But I think that end-of-life care is woefully not taught in medical schools or in environments where it should be. A lot of information given to providers so that they can better educate their patients and care for them. Instead of, dropping them down a well and, okay, you have this terminal diagnosis, and but at the time, they didn't even tell me that it was a terminal diagnosis. I knew of this condition, and I had studied it somewhat, but the reality of wheelchair use, bedridden stuff, not being able to move, speak, swallow. I'm already experiencing a lot of dysphagia now, which is the medical term for difficulty swallowing. And for example, yesterday I had an occasion of low blood pressure, and I needed to take some midodrine, 10 milligrams of midodrine. It's a pretty big pill. It's deeply scored, so it would be easy to cut in half. Some of these things, these pasty pills like midodrine or gabapentin is a very common medication. Millions of people take it, and I take a 600 milligram dose. The pill is pretty big, and so sometimes need to use applesauce or a pudding, to kind of get it down safely. But yesterday I did aspirate on the midodrine, and it was not fun. Just put it that way. So there are elements in the delivery of this diagnosis. And they did a timely workup because at the time that the diagnosis was given, I was fairly able. I think I was still driving then, or maybe not, because I had consulted with my movement disorder specialist when I started to experience problems parking my car. That one time I bent my mirror, my side view mirror, my driver's door on my carport. No lasting damage though. The mirror was easy to flip back into position. And there was one time I bumped into a fire hydrant. Happily, there was no mishap there. And the irony to me is that at one time in my life, I used to fix fire hydrants for a living. So, yeah, that was kind of a trippy thing. But I went to my movement disorder specialist and I said, maybe it's not safe for me to drive anymore. I probably could have driven, long past that. I have an acquaintance here who's in his 90s, and he still drives. He still runs red lights and stop signs and stuff, but he's still motoring around. I don't really like to be a passenger with him, but, but gee whiz. What are you going to do? But anyway, if you're a provider and you happen to see this, wake the hell up, man. This is not the way to tell your patients that they have a terminal disease and the progression is going to look like, boom, 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 and these are your options. And also these conditions come with a host of medical problems that must be addressed in a multi-clinic fashion. So just outsourcing referrals for gastro, neuro, psych, PM&R, nutrition, all of these people who must be carefully integrated into the patient's treatment plan, I think is absent, at least in my case, because many of these referrals were informal, like in the office, write down the name of this guy and call it, And so, but when I call, I find out that he's not taking patients, or he only does telehealth. And that was at a point when our Medicare officials decided that they were going to stop reimbursement for telehealth. They eventually reversed that position, but at the time when I was trying to make an appointment with this character, it fell through. And there was also other times when I got referrals from a provider who referred me for a cognitive behavioral therapy program at a behavioral clinic that is 40 miles from my front door. And wow, and what makes it kind of bemusing, I suppose, is the fact that she is the same provider who wrote the medical justification for getting handicap ride services. And she also knew that I do not drive. And so I don't expect her, to follow my case, like a biography or something, but I think that these are elements of my patient situation that providers are not paying attention to as keenly as they may. I suppose this is the reality of it. In some cases, your mileage may vary, and I hope it would. So in the meantime, hold on to your hat. It's a wild ride, and obviously there'll be more. Thank you for watching and paying attention to my content.